Welcome to Evidence Base, a new Harbinger psychology podcast. I'm your host, Cassie Stossel. On today's episode, we're talking about psychosis. Our guest is Maggie Mullen, author of the Dialectical Behavior Therapy Skills Workbook for Psychosis. Maggie is a clinical social worker, national trainer, and community activist with over a decade of experience helping people navigate psychosis. They specialize in culturally responsive, evidence-based care for psychotic spectrum disorders, trauma, post-traumatic stress disorder, the LGBTQ plus community, and formerly incarcerated people. As a training director at Kaiser Permanente, they take great pride in mentoring and teaching the next generation of social workers. Maggie lives in Oakland, California with their spouse and 2 cats. You can find out more online at www.maggiemullen.org. Hi, Maggie. Thanks so much for joining me today.
Of course. Thanks for having me, Cassie. I'm excited to talk a little bit more about DBT and psychosis.
Me too. I'm really fascinated by psychosis, and I think, psycho is definitely like an overused term. I think we are commonly misrepresenting what that term means. So I was hoping we could start by you just sort of telling us what is psychosis and what are some of those common misconceptions.
Absolutely. And I think your point is a really good one. So I think it always makes sense to start here. So psychosis is considered a unshared experience, meaning something that if you and I were in the same room, we would not share, right? It's not a common kind of experience. So for example, I tell people like, I grew up in Texas, and there are cockroaches everywhere. It's just like a reality of being in Houston. And one of the things that will happen when I go home to visit my family is I will see a cockroach, and for like the next like 3 hours, I have this sensation periodically of like bugs crawling on my skin, right?
Mm-hmm.
That's an experience of like a tactile hallucination because I look down, there's no bug on my skin, right? And so people experience these all the times. And I think one of the misconceptions about psychosis is that only people with schizophrenia or a psychotic spectrum disorder actually experience psychosis, when all of us actually do. It's a common human experience. And for people with maybe more of a chronic or acute psychotic condition, they tend to experience those things maybe in a more disabling or interfering with their day-to-day life and reaching meaningful goals kind of way. And I think when you mentioned before that idea of using the term like psycho, for example, or calling somebody psychotic as sort of a slur, I think one of the assumptions behind that is that people who experience psychosis are dangerous or violent, right? That's
Mm-hmm.
a common thing that I think people kind of come up with in their head around that. And what we know is that people who experience more chronic psychosis, so kind of psychotic spectrum conditions, are actually more likely to be victims of violence.
Mm-hmm.
And so I think this is a really important clarification for people that what we often see that's concerning to us is that folks are experiencing disorganized behavior or speech, right? Behaving in ways that are maybe more erratic because they're responding to what's happening with their psychosis. Again, when it's really acute, when it's really flared up. But those folks are actually not super likely to be dangerous. They might engage in behaviors that are confusing to you, but that doesn't automatically mean that that's going to be dangerous to you in some way. In fact, it's more likely that they might be a danger to themselves in that situation.
So psychosis is a symptom, not a diagnosis. Is that correct?
Yeah, and I even think about it as an experience rather than a symptom, right? Because it doesn't always have to be a negative thing, right? For example, a lot of my folks hear voices, right? Auditory hallucinations, but they don't bother them. In fact, they can sometimes actually be, kind of an experience that feels like reassuring or calming to them, similar to the way that like when we experience grief, we often like see or hear our loved ones' voices later, right? We like maybe see them around the corner of the room. Sometimes that can be distressing, of course, but other times it can be soothing to think that we, are able to still be in contact with our loved ones. So that's the reason why I reframe it as like an experience rather than a
Mm-hmm.
symptom.
What are some common mental health conditions that these experiences come up with? You mentioned the spectrum disorder and schizophrenia. Are there others?
Absolutely. So depending on how we want to look at this, right, from kind of the medical model using the DSM, there are a number of schizophrenia spectrum disorders, meaning people who are experiencing chronic psychosis as part of a mental health issue. So that certainly includes schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features. And psychosis can occur in a lot of other types of diagnosis or mental health issues too, right? So we see it really commonly with folks experiencing depression at times. We see it amongst folks who experience borderline personality disorder. It's a fairly common thing to hear voices, for instance, or have distressing beliefs that might appear as delusions or even paranoia at times. We also see it in a lot of medical diagnoses. And I think it's interesting to talk about it from that perspective because It's not uncommon for people who experience delirium or dementia, for example, or certain
Mhm.
hearing or auditory issues to have hallucinations as part of that. And we also see it obviously with drug use, right? It's not uncommon for people to actually seek out psychedelics, for example, because they want to experience, a different, unshared plane of reality. And that's really what a psychosis looks like for most people.
You kind of got into this a little bit, but can you elaborate on in your book, you talk about positive and negative experiences with this. And you kind of mentioned it, with that comforting of a loved one, but can you go a little bit more into the differences between the two?
Absolutely. So I always like to kind of preface this with positive and negative are definitely like medical terms in this, right? Positive and negative don't mean good or bad in this case. It really refers to something that is added that we don't expect to see there, or something that is missing that we expect, right? So when I think about what's added that might not normally be there are things like hallucinations, right? In all five domains of senses, for instance. It could be disorganized thinking or behavior, or what we used to call delusions, we really call in more progressive kind of approaches to psychosis, distressing beliefs that are really fixed for people. Those tend to be the most common positive symptoms or experiences. On the other hand, the negative experiences are, again, things that we expect to be there but are missing. And what you'll notice is they look really similar to depression, right? So a lack of motivation, anhedonia, right? Lack of pleasure from regular activities you get pleasure from, difficulty concentrating, lack of desire to engage socially, having a flat affect, which is a fairly common negative symptom amongst people experiencing schizophrenia, for instance. And again, it's complicated, I think, in this way because medications for those people who take meds are pretty good at treating positive symptoms. They are not very good at dealing with negative symptoms or experiences. And those tend to be the ones that I often work on a lot with my clients because they are the ones that often get in the way of meaningful life, right? Like when you feel like you can't get out of bed or you don't want to be around people or your affect is so flat that people can't read your emotions, your expression, that tends to get in the way of what we call in DBT, like building that life worth living and the things that you want to be doing with your time.
Yeah, and when somebody is sort of in an episode, do they know they're sort of experiencing this, or is it after the fact where they're coming to terms with what they experienced, or how does that work for someone who is experiencing psychosis?
It depends on the person, right? So I think of this as a spectrum of experiences. There's a clinical term, it's called a nesanosia, that refers to the idea of like lack of understanding or lack of insight that it can occur in psychosis. And my experience is that people sometimes have a consistently different level of insight or understanding about their experience, and other times it varies based on where they're at. Meaning, when they're experiencing, let's say, like mania, for instance, they might be much less likely to think about themselves as having a mental health issue or think about themselves as dealing with this than they might when they're more stable or at their baseline. So there's a lot of variation amongst folks in this regard. And one of the things that I always like to add in is we are often trained fairly quickly as providers to assume that somebody is experiencing a lack of insight rather than, and pathologizing that, rather than assuming they might actually have a different understanding of their own experience. Meaning that there might be a spiritual or religious explanation or understanding of what's happening, or just a different cultural explanation for what's going on. And that doesn't need to always be pathologized, right? Sometimes that's not a problem for people, or other times we need to approach it in a different kind of way because our right way of, oftentimes medicating these types of symptoms or experiences out of clients is not actually in their best interest or what their goal is, or even what's safe for their bodies, too. So I would say I think the trickiest experience for clinicians is dealing with this like anosognosia experience that can happen because it's hard, right? I don't want to like sugarcoat that piece either. It's really hard when somebody doesn't believe that what they're doing doesn't make sense or is not unsafe when it actually is, right? We can kind of see that from the outside. So it is very challenging at times.
Do you find that that's pretty common? When can people know when it's time to seek that outside help?
Yeah. People come to me in all different types of walks of life, right? So I have folks who are experiencing maybe what we call prodromal psychosis, right? Really early signs of things starting to develop before anyone's had a more acute episode. And then I have folks who've had years and years of psychosis who are, in their 70s, right? And coming to me maybe for treatment for the first time. And part of that, of course, is like lack of access to treatment and a number of things that can be barriers, of course. Um, and I think at the end of the day, I tell people we live in a society that really emphasizes self-care. Now, I'm a fan of self-care. I like the idea that we need to take care of ourselves and put ourselves above others. There's nothing inherently wrong with that. And I think the piece that gets missing is the idea of community care, the idea that none of us can operate alone in society. We always need to depend on each other, right? As much as we sometimes want to separate ourselves from others. And like I mentioned earlier, when you're experiencing negative symptoms of psychosis, you actually may not want to be around people, right? Like that is part of the experience of that, is that maybe you feel really isolated from others. So that can get in the way a lot of times. But I often really emphasize to people that getting help, even if you're not sure you need it, from your loved ones. It doesn't have to necessarily be from a mental health treatment system, of course. There's a number of different supports people can get. But being able to ask for that help, I think, is such a strength that people have. And something I really try to emphasize is figuring out how and when to ask for help and really developing a skill set of how to be direct with those questions, right? Using like interpersonal effectiveness skills, for example, from DBT, of like how to ask for what you need, essentially.
What can bring on someone's sort of first like sign of psychosis, or what do those first symptoms look like?
Yeah. So the model that I come from is this idea of the stress vulnerability model. And the stress vulnerability model is essentially that idea that both genetics and social experience are important in the development of mental health issues, and particularly psychosis. It's really similar to like the biosocial model from DBT, if we kind of turn to that, that describes somebody's capacity for emotion regulation. So the stress vulnerability model basically says genetics are at play, right? So we know if you have a first degree relative with a psychotic spectrum disorder, you are at higher risk of developing that yourself. And you also need to probably experience stressors, right? Environmental things that could be happening in your life that would increase that likelihood. So those look like things like environmental risks, right? Unstable housing, trauma, bullying, heavy drug use, etc. The typical types of things. I think the other thing, though, I think that gets missing from the equation, right, is the protective factors. Like, what are the things that help people not to develop a chronic psychosis, or at least help keep it in check while they're experiencing it? And that's things like social support, coping skills, access to resources, both financial benefits wise, etc. And so that's a big part of my work, is focusing on building up those protective factors to help kind of people avoid an episode. Now, going back to your original question, since I took us on a little bit of a tangent there, what those early experiences of psychosis can look like, kind of that prodromal phase, is of course different from everyone. But I think of those as significant changes emotionally, in terms of like somatic sensations and thinking, as well as emotional changes from somebody's baseline, right? So a lot of times what I see is, a teenager, for example, whose parents are bringing them in because their grades have dropped significantly. They used to be fairly social or engaged in social activities. They are no longer doing that. They're keeping themselves. They might describe themselves as like seeing things out of the corner of their eye, though not necessarily. There's often a description of like feeling like they're losing their mind or they're going crazy. That's a really common thing that I hear. And that's kind of actually some of our early screening questions around prodromal symptoms for people. So it can look similar to other things at times where we're not quite sure. And that's why early intervention screening is so important, because we can really intervene early and reduce the likelihood of somebody experiencing more chronic psychosis at that point too.
I'm curious if you've noticed sort of an increase in folks coming for help for this, like post COVID, post sort of all these major stressors that we're experiencing as a collective, plus like, the more isolation we're experiencing, since you mentioned community is a big part in that protective measure. I'm just curious if more people are experiencing this now.
Great question. I can speak just anecdotally. I don't know what the research is pointing to just yet in this regard. Yeah, absolutely. I think what we're seeing is a lot more young people in particular who were very isolated, who didn't get the same like social and developmental skills that they would have, coping skills, anxiety skyrocketing, etc. And I think just thinking about that from their perspective, like an environmental stressor, right? Something out of your control that is really intense and it's hard to cope with. That's something that's going to, in from that this kind of biosocial model we were talking about before, that's going to increase your likelihood of developing things that you might be predisposed to biologically, for instance, or genetically. And so what I've seen in my clinic and the work that I'm doing is that we have more folks who are coming in and who are being caught in settings like the school or in their primary care office or other kind of non-traditional places, which is actually where we want them to be caught because that's where people want to be out in the world. They're not usually in mental health treatment, but who are struggling with this type of thing. So I think I've seen anecdotally certainly an increase in that of folks who are seeking help overall, particularly who are dealing with a lot more suicidality overall too, which is a not uncommon experience for people who are experiencing prodrome, right? If you think you're losing your mind, if you think you're developing a psychotic disorder, the suicide risk rate goes up significantly. We can kind of understand why that might be the case.
Yeah, absolutely. And something I've noticed, obviously, I don't know any research, but there's an uptick in people talking about just general mental health on places like TikTok, where I think maybe more people are seeking treatment because they're recognizing themselves in symptoms. And this is maybe a tangent question, but have you ever seen like a good representation of psychosis in any media? Things are commonly misportrayed and over exaggerated. Have you ever seen anything that was close to what the actual experience is like?
Yeah, I would say certainly, like, all of the bad media side, which it feels like there's overwhelmingly so much of it to sort
Yes.
through. My experience is the best, let's say, like, social media accounts or places or organizations to follow for, like, really good information are the ones that are led by people with lived experience of psychosis, right? I really find personally the most benefit from following those accounts, and people sharing what day-to-day life looks like, right? And being able to really track the trajectory of somebody who's sharing, like, good days and bad days and in between days and everything like that. For instance, there's an account that I follow that I really love called Psychosis Positivity, run by Rose Parker, who I really enjoy, who does a really good job, I think, now as somebody who's a psychology student and entering into grad school to become a therapist, talking about their journey both from the personal perspective, but also the perspective of what does it look like to be trained as a mental health clinician when you're experiencing this yourself too. So I always emphasize to people, like, find accounts or media pages or organizations that are really led by the folks who are experiencing this themselves, because they are the folks who should have the loudest voice around this topic.
Yeah, absolutely. So I'm curious, is DBT the standard treatment model for psychosis, and why is it so effective?
It is not. So let me give you like a little backstory before I answer that question. So for what feels like forever since the dawn of psychology, we have done a really bad job understanding and treating people experiencing chronic psychosis. And part of that is due to like misunderstandings of people experiencing psychosis. And part of it has to do with, I think, fear to some degree. And so, for example, like if you're somebody who's like kind of a nerd like me, one of the things that I do is I regularly look at the research to figure out what's happening in like terms of psychosis research, what's going on. And one of the things when I look at a research intervention is more often than not, the research study will have a line in it that says exclusionary criteria for this trial was people experiencing psychosis, meaning folks with schizophrenia, schizoaffective disorder, et cetera. So what we see is systematically people with psychosis are excluded from research trials, as well as certainly like groups or various clinic spaces or mental health treatment, except from people who tend to specialize in this area. So what that means is there's kind of crappy research still. It's growing and I feel very excited about that, but it's still not amazing. And then I think a misunderstanding, right? So because of some of the negative symptoms of psychosis, where folks, for example, express and experience emotions in a different kind of way, meaning like if their affect is very flat, it's hard to tell they're experiencing that emotion dysregulation. I think for a long time as providers, we just assumed they weren't experiencing emotion regulation or weren't experiencing emotions in the same way. And what we know now from newer research around that is it's not true. Folks experiencing psychosis actually deal a lot with emotion dysregulation, and that it is a linchpin in the vicious cycle of psychosis getting worse, right? Meaning that, for example, having a strong emotion or emotion dysregulation can influence your experience of psychosis, which would make sense, right? Those kind of influence each other in a negative way at times. So to get back to your original question, DBT has, I think, in its original sort of Marshall Linehan Red Book text from 1993, kind of our like DBT Bible, actually talks a little bit about psychosis. And what she says in that book essentially is that while there hasn't been extensive research done around psychosis in terms of the research trials done in DBT, that as long as somebody can grasp the concepts of DBT, meaning that they can understand what's happening in group and individual therapy, they should be included in this treatment. There's no reason to exclude them. So I think for a long time, the primary intervention was CBT for psychosis as soon as we finally started doing individual therapy with people experiencing psychosis. And I love CBT for psychosis. That's what I was originally trained in. And I think what DBT holds, in my opinion, is more of the B part, right? More of the behavior and ways to target emotions, in addition to the good work that CBT does targeting thoughts. And I think for a lot of my clients for whom they are really stuck in distressing beliefs, again, formerly delusions, being able to do behaviors that might change their thinking or might change the way that they're experiencing their emotions, actually, they're more likely to want to do.
Okay, yeah, that's a big difference. Yeah. So in your practice, do you mostly pair the two, CBT and DBT?
I tend to do both, but it also depends on the client, right? So I tend to get refer to a lot of people who really want to do DBT because that's kind of who I am. And also, like, I resonate a lot with DBT too. It's kind of like the language that I speak and the way I move through the world. And so that kind of makes sense. And I find that they go together really nicely, and clients like to have interventions that come from both. And so I try to do a little bit of both. Now, if I'm dealing with clients, though, who are dealing with, like, let's say, self injury behavior or suicidal ideation, which is fairly common amongst people experiencing psychosis, DBT was really developed for that, right? That emotion dysregulation that causes those types of thoughts and behaviors. And so that's always going to be my go to in those situations. And I think my clients tend to really like that part of it.
We'll be right back after this short break.
Hi, I'm Dr. Daniel Fox, author of the Borderline Personality Disorder Workbook. When you first are diagnosed with BPD, or you're first told that you may have borderline personality disorder, it can be very frightening and overwhelming because we have these ideas of what this disorder is, and you can feel trapped within it, trapped within this view or perspective of this thing that feels bigger than you and bigger than life. The reality is that this is a disorder that can be managed, and that learning adaptive strategies can help you control it and do your life differently so that you determine the course of your life, not your BPD. To learn more and to sign up, go to bpdcourse.com.
In your book, you talk about mindfulness playing a role with psychosis. Can you talk about that and what are some ways to practice it?
Absolutely. So, mindfulness, way before DBT and sort of before we did even a lot of research around CBT, there's been a decent amount of research around mindfulness being effective for people experiencing psychosis for essentially the same reasons as it benefits the rest of us, right? That it helps us with concentration, attention, with emotion regulation, with awareness, etc. And so I have always really drawn from mindfulness as a practice to help my clients. And of course, because I'm trained as a DBT person, I do mindfulness myself. That's a really essential part, is kind of practicing what you preach. And with psychosis, the modifications I think that tend to make it most effective for our clients, and again, this is individual to each person, but generally the guidelines that I like to follow are being able to choose shorter times, right? So more of a time that a person can tolerate to do a mindfulness activity, because sometimes things like internal stimuli or voices or various things can get in the way of doing this a longer time. We need more guidance, meaning walking people through things in less periods of longer silence. So, really being able to say, I want you to focus right now on what you're noticing in your body, what's going through your head. And specifically, the last kind of piece of guidance is in that when you're walking people through a mindfulness, giving explicit and normalizing mention to experience of psychosis, right? So, being able to say, you might notice thoughts running through your head right now. You might notice even some suspiciousness popping up or some voices that are distracting you. Go ahead and gently bring your attention back to your breath, for instance. And really, I think that just normalizes the experience of psychosis, because that may be something that's coming up for our clients. And for some clients, I pivot, and doing something that's internally focused is just not going to be a good fit for them, either at that moment or in general. And what we know about mindfulness is you can do literally anything mindfully, right? It's about using the how and the what skills to do it successfully. And so I can have them brush their teeth mindfully, right? We can do a walk around the clinic mindfully. Anything is an option as long as we're really focusing on how they're doing it, and what they're doing as they do it.
Yeah, I find for me that I need sort of that guidance of mindfulness. Like the sitting silently doesn't work for me, but I try to like eat mindfully and like focus on, the taste and the experience. And that's how I found sort of my way into mindfulness is and to make it more accessible for myself because the whole like sitting on a meditation pillow like just doesn't work for me.
Absolutely. Yeah. And one of the things that I really try to practice with my clients and also personally is mindfulness of uncomfortable experiences, right? Marshall Linehan talks about the idea that, like, yes, when you're in your quiet space with the door closed and no one around you sitting on your little pillow, like, that's actually the time you're least likely to need mindfulness. Meaning, like, we need to be mindful when we're like in traffic, pissed off at somebody, and we don't want to, like, we
Yeah.
want to avoid flicking them off or whatever, right?
Yeah.
I was in a spin class yesterday and I like sort of hate spin, but I'm there because I'm like, I got to get my exercise in and
I
it's
get
a
it.
social activity. And what I will often do when I'm in class is I'm like counting down the minutes. I'm like, okay, I'm 1/3 through class, I'm a halfway through class, etc. And yesterday I was like, I'm going to manage being present in this moment and aware of how uncomfortable my legs are, right? That like my legs are on fire. Here's the sensation I'm noticing. Here are thoughts that are running through my head. And that, I think, is the way we build distress tolerance skills actually in general, is to be able to tolerate things that are generally safe but are painful for us or difficult to get
Mhm.
through too. So absolutely, I feel you on that, Cassie.
I totally relate to that spin class. The love-hate relationship is super real.
So real, yes.
One of the aspects of DBT is distress tolerance. Can you talk about what that is and what are some ways to increase it?
Yes. So distress tolerance skills are ways to get through a hard situation without doing something to make it worse. So, kind of like that example I gave earlier about when you're driving through traffic, for example, a car cuts you off and you want to flick them off, or you want to cut them off, or any number of dangerous things that you could engage in. This is when those skills are really helpful. When you're in a crisis situation, you can't change just yet, and you need to reduce the intensity of your emotions so you don't do something that comes with consequences later, essentially.
Mhm.
And distress tolerance skills, I think, are super helpful, particularly at the first stages of treatment for people, because we can't quite use emotion regulation yet, right? We need to get to a place where we can actually modulate or regulate our emotions enough to then work on changing them or work on problem solving the situation. And so the common things in DBT that show up for distress tolerance are things like using pros and cons, meaning like going through and really thinking through, is me acting on this going to serve me long term from a wise minded perspective? They include things like distraction, right? And distraction doesn't mean like you binge watch 12 hours of Love is Blind, for example. This is like I watch one episode and then I come back because the original problem is still going to be there. I'm not speaking from experience or anything.
Totally
It
attacked.
might be, it might be things like the tip skill, which involves using essentially things to physiologically change your body's response to change your emotions. So using temperature, using intense exercise, pace breathing, progressive muscle relaxation. It can include self soothing, right? A lot of distress tolerance at the end of the day are actually things a lot of my clients and people I know are already doing, but doing it in a much more intentional way and really targeting them in a way that's going to be most effective. So they don't turn into avoidance, but are actually really useful tools to use. So a lot of them are quite intuitive.
And a lot of the ones you mentioned involve the body. Can you talk about some strategies for changing your body's response to stress?
Absolutely. So, going back to that tip skill, for instance, so one of my favorite interventions, and I think actually most DBT's favorite interventions, is the temperature part of tip, the first part of the skill, which is essentially the idea that you are trying to simulate something called the mammalian dive reflex in your client, or again, in you if you're using it yourself. And it is essentially something that happens to all mammals because we require oxygen to breathe, right? That when we go underwater, particularly cold water, our nervous system starts to slow down in an effort to require less oxygen, right? So that we can stay under the water safely for a longer period of time. And so when you notice when you get physiologically aroused, right? Meaning when you have emotion dysregulation happens, right? Your heart rate goes up, your breathing is shallow, like all of those kind of physiological signs happen. And so when we use tip, or the first part of tip, the temperature skill, we're actually working intentionally to decrease that arousal so that we slow our body down. And one of the ways I will use this a lot of times if I'm teaching in a group is I have people use a heart rate monitor. I'll bring one in from group, particularly because I work in a hospital, we have easy access to that. And I will have them. So there's two different ways you can do it. The first is you have a cold bath of water, right? So it can be like you fill up, your sink with water, or a cold bowl that I bring in with a little bit of ice, for instance. You put your face in it, hold your breath for maybe 20 seconds, whatever's safe for you realistically. And then you take your head out, take a break, see how you feel. You can do it again if you need to and repeat. And if you were measuring your heart rate, what you'll notice is your heart rate decreases significantly during that time, which makes it easier to go back to wise mind, essentially. Now, the other way you can do this is with an ice pack, because not everyone has access to running water at any given point. And I will often recommend my clients use those little first aid icebreaker packs that you can kind of just break anywhere. You can use a bag of peas from your freezer, it doesn't really matter. And the idea, same thing, you're putting those over your orbital bone, so the bone beneath your eyes. You're bending over as if you're dipping your face into cold water, and you hold your breath. Same thing, 20-ish seconds, come back up for air, take a break, see if you need to use it again. And it's pretty amazing how quickly this skill works for people. And I think a lot of my clients in particular like it because it doesn't require them having to think their way out of things. It really involves like a kind of a unique activity that really gives them fast results.
Is this why people are drawn to the cold plunge these days?
That's a great question. I don't know, because they stay in that cold water a long time is what I can tell from these
Yeah.
videos. I think so. I don't know the answer to that, honestly, but maybe I would imagine if you're putting your face under it has the same effect, because that's really what you're trying to go for with the tip skill.
Yeah, yeah. In your book, you talk about harm reduction. Can you say more about what that is?
So harm reduction is actually kind of exactly like what it sounds like, meaning you are trying to reduce the harm that an activity can cause in your life. And harm reduction is also a bigger movement, right? Around, like, we see this most commonly, I think, for injecting drug users, for example, about having clean needle exchanges, safe injection sites, et cetera. But harm reduction can also apply to not just drug use, it apply to kind of any risky behavior. And in DBT, we talk about harm reduction as one of the balancing skills that we're trying to use when we're helping clients achieve more of a dialectic or a balance when it comes to their substance use. But again, these skills apply more than just to drug use, although certainly that's a common issue amongst our folks experiencing emotion dysregulation. Now, what we know about psychosis is many folks are dealing with drug use issues. And for good reason, right? If you're dealing with a lot of really intrusive thoughts or voices or seeing visual hallucinations or whatever, you're going to probably self medicate. That's not an uncommon thing for people to kind of jump to deal with all of this, especially if they don't have access to psychiatric care on top of that. So, one of the goals that I have in doing this work is we can't ask for abstinence from all of our clients. It's just not realistic for everyone to pursue that path. And this is to some degree where I diverge a little bit from the DBT model in this regard. And when we're thinking about applying this to psychosis, what I think is actually most important, particularly as we're helping people maybe reduce their use or finding safer use, is we find things that they can do that reduce harm for them, right? That reduce things that are going to essentially have long-term consequences for them, for instance. So again, that involves certainly what I mentioned before, like needle exchanges or using with other people, testing your drugs, for example, before for fentanyl and various things, for instance. But it can also involve things like, right, sex work. There's harm reduction work that we can do there for our clients who are engaging in that, for example. It can look like that for even self-harm behaviors. So it doesn't mean that we're not asking for our clients to get to a safer place with their use, but we're asking them for safety along the path of that journey as well.
I think that's a really good distinction too, because like you said, like asking for that abstinence isn't the most realistic path there. We talked a little bit about this earlier. Like obviously the community is important. The first step for people, in theory would be like talking to their family or friends about this. But what are some common communication barriers for folks experiencing psychosis to connecting or to getting help or to talking about what they're experiencing?
There are four that always come to mind for me as most common, though certainly I'm sure that there are more than that. So the ones that tend to come to mind for me are suspicious thoughts, right? If you feel like you can't trust the person in front of you, you are not going to communicate clearly with them or honestly
Hmm.
about what's happening. It's hard to be forthcoming if that's the case. And I think what kind of comes along with that is also trauma and PTSD, right? So again, if you can't trust that person because of maybe past traumatic experiences or even like their racial background, for example, there's a power imbalance that's there. You may not disclose fully about what's going on, or that might get in the way of your ability to get your needs met, for example, if you've been punished in the past for asking for that. Now, there's also things like social anxiety, right? Around a third of our clients who are experiencing schizophrenia also experience or meet criteria for social anxiety disorder. And so when you're socially anxious, it's real hard to communicate, as you can imagine. And then lastly, negative symptoms, right? What I talked about before of like if you have a lack of desire to engage socially, or you're experiencing flatter affect and it's hard for people to read what's happening for you, or you're simply just not getting pleasure out of social interactions like you used to, that's also going to get in the way. So when I work with clinicians or loved ones who are, kind of helping to support somebody experiencing psychosis, I really try to explain all of this stuff to them to both be screening or thinking about this and also thinking about there are plenty of ways that we can help our clients become better communicators, knowing that these might be potential barriers if we're aware of them. So that's something we can absolutely integrate into the interpersonal effectiveness skills module, depending on what the source is, right? Meaning if it's social anxiety, we might be doing some exposure and response therapy for that to help somebody work on that. Or if it's trauma or PTSD, how do we work on folks understanding a real sense of safety, like kind of readjusting or calibrating that within their body and their brain, and maybe doing prolonged exposure as part of that, et cetera. So different interventions we can use that help kind of target and increase somebody's ability to be a more effective communicator. And again, get their needs met, ask for help, all those good things.
Yeah, that's so important. And I have to imagine that there's some level of or a large level of shame that's involved in sort of having these experiences that people maybe don't necessarily want to express to people for fear of being misunderstood.
Absolutely. Yes. I think one thing I haven't spoken on, I'm so glad you're bringing this up, Cassie, is social stigma. There is huge social consequence to experiencing psychosis in a visible way, right? Sometimes that's like microaggressions or interactions that involve the things we say to people, right? Language that's like ableist or sanist, like you're crazy, you're psychotic, or any of those things that we've mentioned before that are used as slurs, to all the way to people calling the police on you, for example, if you're communicating with yourself in a public way. And so we always have to account for those power dynamics when we're working with people experiencing psychosis, particularly if, BIPOC and folks of color, when we're doing this work. Because if I'm telling a client to actually communicate directly with their voices, I have to also tell them what are situations that are going to be safe to do that and what are situations where, again, somebody might call the police or you might end up incarcerated or institutionalized because of it. And that's a really important thing that we need to integrate as providers is an understanding of environment in terms of being good behaviorists, essentially.
That leads me to ask what would you recommend for somebody like if I was walking on that street and I saw somebody, speaking to themselves or in distress, what would you recommend as a route of action instead of calling the police, for example, or calling somebody? Like is there a way to help somebody in that moment?
Absolutely. So I think the first thing, beyond like being somebody who out of the goodness of your heart wants to help, it's also so important to have some level of training if you're going to intervene in a situation like that, right? And that's like mental health first aid training that can be really helpful for people that, often integrates non-carceral, so like non-police, non-institutional solutions in a situation like that, because of some of the, again, disorganization people with psychosis can experience. Again, we may not actually be effective interveners if we don't know how to navigate that, right? We might get scared more easily or feel like we have to protect ourselves or something like that. So I think in an ideal scenario, which is not always accessible to all of us, that would be a first step for folks that I always recommend. And there are other things that we can do too, right? We can ask if somebody needs help, right? That's like one of the things because
Mhm.
somebody might say no, and then we need to respect that, right? That's an important part of this.
Yeah.
It can also be, for example, if you have, a lot of communities more and more are developing non-carceral interventions for people experiencing severe mental illness who are on the street. So, for example, if you have a resource like that in your community, like a mental health crisis team where they're sending out mental health providers rather than police, for example, that can be a really helpful resource for people. This can also involve things like For folks who are drug users, right? We're not always able to tell the difference between somebody who's maybe high on drugs or experiencing psychosis or both, right? So having access to things like Narcan, right, and getting Narcan training can be helpful from a harm reduction perspective if you say somebody who seems to be incapacitated in some way on the street. So this is all to say, I don't think there's a simple answer to that question
Yeah.
other than like respecting somebody's limits, getting maybe some own training of your own, and really thinking about what the consequences of your actions might be if you are to intervene and who you actually call. And I think those are the questions maybe to ask yourself in a situation like that in order to intervene most effectively.
Yeah, definitely. Thank you for answering that because I do feel like this is something that people are experiencing more commonly coming into interaction with people who are struggling, and I think people always don't know what to do to help. That isn't going to cause more harm.
Absolutely. And I think, maybe even one question to kind of think about in addition to what I've shared is like, is there a safety risk here? If there's not, like, do you need to get involved in somebody else's business, for example,
Yeah.
unless they seem like they're in some level of distress? Versus, can you actually mind your own business because we're just existing maybe in different ways of existence and we can kind of honor their neurodivergence in that type of way?
Yeah.
So, some of that I think comes back to those norms around like ableism and what our assumptions are about people. But again, I think this is extremely messy. And I think from a bigger perspective, we simply need more access to services for people with mental health issues. That's part of why we're seeing, I think, more and more people on the streets, unfortunately, who are not getting support and maybe who have worsening or more acute kind of symptoms or experiences of psychosis too. So, I think both of those realities are very real right now, unfortunately.
Yeah, that makes a lot of sense. And one thing that stood out to me in your book was you say that recovery is possible. I think that's a really powerful note to end on. So I'm wondering if you can say more about that.
Absolutely. So, when we're thinking about recovery, I like to tell people recovery means something really different to every person. And sometimes recovery also looks like adjusting your expectations too, right? Maybe we thought that we were going to be in a different place in our life, but things happen, including developing maybe a chronic mental health issue, right? The same way many of us have developed chronic pain issues or a medical condition or things like life changes rapidly, right?
Hmm.
And so part of what I think about in this regard is what does it look like for you at this point in your life to build a life worth living? Right? What does that look like for you as an individual to engage in meaningful activities in your life, to care for yourself in the way that makes sense, to engage in satisfying relationships, to participate in community activities, etc. And really creating a map for what that looks like for yourself and being able to work towards that. And again, that's going to look different for each person, but it can be a real motivator for a lot of us to achieve recovery in that regard. And I think one of the misconceptions over the years is recovery means like no symptoms, right? Or no
Hmm.
experiences of psychosis. And I think, again, this more progressive approach really from disability justice says, how do you live this life worth living and experience psychosis at the same time? Because we may not be able to take that away, and you may not want that to be gone too. Maybe the work instead is on acceptance and developing a more positive relationship with your experiences of psychosis so you can coexist and again continue to live that life worth living with that a part of the ride for you too.
Yeah. Thanks so much, Maggie. This was great. I think that's a good place for us to wrap up.
I super appreciate your time, Cassie. It's always wonderful to talk about this, and I appreciate it.
Powerful and effective skills to help you manage psychosis, take charge of your emotions, and get back to living your life. Based in dialectical behavior therapy, DBT, this first of its kind workbook offers real skills to help you balance your emotions and stay grounded in reality. You'll find self assessments, worksheets, and guided activities to help you understand your symptoms and manage them in day to day life. You'll also gain self awareness, learn to navigate difficult or stressful situations, and discover healthier ways of interacting with others. If you have a history of psychosis or suffer from psychotic spectrum disorder, you know how difficult it can be. You may experience paranoia, auditory hallucinations, and emotional dysregulation. In addition, you may feel alienated from your friends and family if they have trouble understanding what you're going through. The good news is that you can move beyond the stigma of psychosis, regain hope, and rebuild your life. This compassionate workbook will help you get started. In this workbook, you'll learn the core skills of DBT to help you feel better: mindfulness, distress tolerance, emotion regulation, interpersonal effectiveness. You'll also find important information on relapse prevention, including warning signs to watch out for, what to do if you have another episode, and an extensive resource list to help you manage your symptoms. And finally, you'll find a wealth of practical tools that can be used every day for a long-lasting psychosis recovery. Visit our website at www.newharbinger.com and use coupon code podcast25 to receive 25% off your entire order. New Harbinger Publications is an independent, employee-owned publisher of books on psychology, health, spirituality, and personal growth. For over 50 years, our evidence-based self-help books and pioneering workbooks have helped readers make positive changes to improve mental health and well-being. Founded by psychologists Matthew McKay and Patrick Fanning, New Harbinger is proud to be an employee-owned company. Our books reflect our core values of integrity, sustainability, compassion, and trust. Written by leaders in the field and recommended by therapists worldwide, New Harbinger books are practical, accessible, and provide real tools for real change. The best continuing education training does more than just fulfill requirements. It opens your mind to new possibilities, increases your confidence, and gives you powerful tools to transform your clients' lives. Praxis Continuing Education and Training partners with world-class experts to create cutting-edge, evidence-based courses for mental and behavioral health professionals. Learn how to heal trauma with Robin Walzer, explore values with Kelly Wilson, and master the basics of acceptance and commitment therapy with Matt Boone through an on-demand course. Or join experts and like-minded professionals live to take your practice to a new level. Find your next training opportunity at praxiscet.com. That's praxiscet.com. Do you have an idea for another episode? Do you want to send us a message? Our email address is podcast@newharbinger.com. We'd love to hear from you. This podcast was edited by Jesse Fancushion. If you enjoyed today's episode, we'd love if you rated, reviewed, and subscribed to the show, and we hope that you might share it with anyone who could benefit from the content. This podcast is not a substitute for counseling with a licensed provider.